Good afternoon, dear students. I'm glad to be here today with you and share some information about significant and fascinating topic, hemoblastosis. What is this? Let's find out together. First of all, I need to underline important point. This point is obligatory. Please register in our live chat so we can see who joined us and mark your attendance. Let's start. As usual, we start with a definition. Hemoblastosis, this is a general term for proliferative disorders of the blood-forming tissue. So, in other words, hemoblastosis is a general term for tumors from blood cells. Again, hemoblastosis is a general term for tumors from blood cells. Move on. Main features. You have already known a lot of features of tumors, both malignant and benign. But group of tumors as hemoblastosis has specific features. These features can help you to distinguish exactly this group from any other tumors. So, first of all tumors that belong to the group of hemoblastosis are malignant tumors. Again, all hemoblastosis are malignant. There is no exception at all. Yes, 20 years ago, 50 years ago, some tumors were suspected as benign tumor or tumor with uncertain malignant potential. But today, according to modern classification, according to modern point of view, there is no benign tumor. It's very important because in the name of some tumors, of some hemoblastosis, we will see ending oma. You know that ending oma is classical feature or classical tip to recognize benign tumor. But in this case, this is an exception. So, for example, lymphoma is malignant tumor. What is lymphoma? We discuss a bit later. So, first feature that all tumors are malignant. Next one feature, as you see, dissemination. You know that all malignant tumors have a feature as metastasis. So, spreading of malignant cells within whole organism. For hemoblastosis, we can't use term metastasis. This is not an accurate term. Why? Because hemoblastosis, as you know, arises from blood cells. Normally, so every day in each organism, blood cells spread within whole organism. So we can't use term metastasis because so where is a place without blood cell? Tell me please, where is it? There is none. Yes, you are right. So that's why we use term dissemination. This term is correct. This term is accurate. So we have either focal version of hemoblastosis, and we have disseminate or general version of some type of hemoblastosis. So we use, instead of metastasis, we use dissemination when we are talking about hemoblastosis. Next one, frequent chromosome abnormalities. We discuss some examples today, and you need to remember, when we are talking about chromosomal abnormalities, the first point, or the most common point, and your first thought should be about hemoblastosis. Next one is the postulate of normal counterpart. What does it mean? It means that each tumor, each name of the tumor in the group of hemoblastosis has a normal predecessor, each. And according to the name of this counterpart, we have a name of the hemoblastosis. This way of naming the hemoblastosis group of tumor actually makes our life easier, so we can easily understand which tumor, actually how each tumor should be named. Okay, and let's come back to the first one. What is immunohistochemical test? What is this? Classically, during our practical classes, we use classical histology. So level of our research is tissue. In other words, we describe with you every class one gross specimen, for example, and one slide. So grossly, we describe organ or part of the organ grossly. So the size, consistency, color, cut surface, etc. Then we go deeper. We take a piece of this organ and make a slide, and then assess this slide under the microscope. And the level of the slide is deeper, and the level of the slide is tissue. So gross description gives us macroscopical changes, and slide gives us microscopical changes on the level of tissue. Immunohistochemical test gives us possibility to see deeper, even more deeper. Here the level is molecular. So immunohistochemical test reveals molecular features of the tissue, of the tumor tissue. And all hemoblastosis, or each tumor from group of hemoblastosis, is needed to be diagnosed by immunohistochemical test. So to make an accurate diagnosis, we need to use level deeper than just tissue. We need to use level as molecular level. Right now we see all these features in examples of tumors. So a few words about accidents. As you see, 1 out of the 10 tumors is hemoblastosis. Here you see list of hemoblastosis, non-Hodgkin lymphoma, leukemia, myeloma, Hodgkin lymphoma. Right now we discuss what are these. So you can see this 7.5% and 6.4%. So mostly each one tumor out of 10 is hemoblastosis all around the world, obviously. So what is this? This is a scheme that shows us again excidency of here non-Hodgkin lymphoma and Hodgkin lymphoma, so of lymphomas. And as you see in Western world, in Western developed countries, Canada, Western Europe, Australia, New Zealand as well. So here we see the high incidence of these problems. Why, you ask? Because here immunohistochemical test is a routine. So there is no problem to make it in each laboratory office. In each laboratory office of the pathology department. In other countries, there is some problem with this test because this test, unfortunately, is expensive. That's why incidence in the countries where this test is not so widespread, so incidence will be lower than in the countries where this test is absolutely widespread. So, etiological factors. Etiological factors, here we have actually a list of them, as you see. Because if you remember, when we're talking about carcinomas, so malignant tumor from the epithelium, sarcomas, malignant tumor from soft tissues. So there we said that yes, some etiological factors are possible, but to be honest, we do not know exactly why and how these tumors occur. In the group of hemoblastosis, we have a bit different situation. There is a real list of etiological factors, and they are really common. They really cause tumors of group hemoblastosis. So the first one, as you see, a lot of types of viruses. I name all of them. So first of all, this one, HTLV1. This is human T cell virus type 1, causes T-cell lymphoma. Next one is EBV, Epstein-Barr viruses. So these viruses cause Burkitt lymphoma, Hodgkin lymphoma, for example. HHV8, so this is human herpes viruses type 8, also can cause Hodgkin lymphoma. And actually this list is not complete. So for you, like students of the third course, you need to be aware about these, for example, 3 viruses. But to be honest, in your MCQ, I do not remember questions about causes of the hemoblastosis. But the basis is updating. So this is a process, and this process actually is happening right now, this updating. So it's really possible that these questions can appear in your MCQ, final MCQ test. So you should be ready. Next one, classical cause, ionizing radiation, and about this cause, some questions in your MCQ test are already. So one of the main cause of hemoblastosis is ionizing radiation. Next one, chemicals, the same situation with carcinomas and some sarcomas, but classically, more commonly, carcinomas. Chronic productive processes as well could lead to the lymphomas and leukemias. And obviously, as usually mostly in each disease, we have heredity. So, this slide presents so-called Philadelphic chromosome. So this Philadelphic chromosome is the main chromosomal abnormalities when we are talking about chronic myeloid leukemia. What's going on here? So we have a translocation from BCR gene on the 22nd chromosome. So these parts go and actually attach to the 9th chromosome, long arm of the 9th chromosome, gene ABL, and makes classical gene ABL-BCR gene. And how can we diagnose this situation? So this is fish. What is fish? This is not just a fish. This is fluorescence in situ hybridization. So this blue cloud is normal situation. So here we have two different chromosomes equal, and here we have the same. And this is exactly this translocation. So when we have one green dot, one orange or red dot, actually red dot classically, and one dot is combined. So two dots become one, green, red. So this one dot is translocation. Another example, again translocation. Here we have 18th and 14th chromosome, and also here we have the same. So part of the one chromosome becomes part of the another. And here, so green dot, red dot, and here you see a combination of both dots. So this means translocation. So this means a combination of these two chromosomes. Combination of parts, obviously, of these two chromosomes. So this translocation is classical cause for so-called follicular lymphoma. We also say a few words about it today. Move on. How malignant tumor actually appears? So we have normal cell, then we have according to the, or due to, more correctly, due to some genetic changes, for example, chromosomal abnormalities, as we said, we have a formation of so-called tumor cell. So this tumor cell, compared with normal cell, has a different, but not absolutely, but different DNA code. It's important. And according to this difference, exactly this one tumor cell can proliferate and make completely different population of the cells. That's why we have, as you see, different in shape, different in size cells. And finally, we will have a population of primary tumor, and here we have polymorphism, here we have hyperchromic nuclei, for example. Here we have increased mitotic rate. Scheme of hematopoiesis. I'm sure that you know this information, but I'd like to revise it. So, first, pluripotential cell has two children. Yes, so this is lymphoid multipotential cell and myeloid multipotential cell. Lymphoid multipotential cell has only one child. So this is lymphocyte cloniforming cell. And then this lymphocyte matures into the lymphoblast and then matures into the B or T lymphocytes. So this column, please look here, precursor cells or blasts, so this column. And this column is so-called matured cells. So classically, for example, in the clinical analysis of the blood, we usually assess presence and amount of cells from this last column, from matured, so-called matured cells. And according to the stage of maturing of the cell, we will name the hemoblastosis, exact tumor from hemoblastosis. That's why I'd like to repeat with you what exactly cells do we have in the whole process of hematopoiesis. So, lymphoid grows and so-called this big part, so-called myeloid grows. So, let's see how we can apply this information to classification of the hemoblastosis. So, after the definition, your teacher always asks you, so name the main groups, name the main types. So main classification of hemoblastosis contains three, again, basic directions. So lymphoid, myeloid, and histiocytosis. Next one, according to the spreading. I come back. No, I can't. Okay, no problem. Previous classification, so lymphoid, myeloid, and histiocytosis, this classification according to the predecessor. So what type of predecessors grows is it? Or lymphoid cell or myeloid grows. This classification leukemia and lymphoma. So this classification is according to spreading of the tumors. So leukemia, we are talking about widespread process. That's why the main features of leukemia are problems with bone marrow and problems with blood analysis, clinical blood analysis. Again, when we are talking about really widespread process, so we name it as leukemia. And how can we prove this point of view? So we need to take a biopsy from bone marrow, and here we see a lot of tumor cells, and also we can, and actually we should, check the blood, and in the blood we also find a lot of blood cells. So this is leukemia. Lymphoma, oppositely, is a focal situation. So there is no general dissemination classically. So lymphoma usually affects lymph node, one or group of lymph nodes, or some organs, for example, spleen or thymus. And right now we need to combine all these classifications, I mean according to the type of the growth and according to the spreading. So leukemia could be divided into two groups as well. First one is acute and second one is chronic. What is the main difference between these two? Acute leukemia means that the source of this tumor is blast. Chronic, the source of this tumor is site. So lymphocyte. For acute, lymphoblast. Right now we see the scheme of the hemoplasm again and conclude this point. So acute leukemia could be acute lymphoblastic leukemia and acute myelogenous leukemia, so-called ALL, AML. So acute, according to the presence of blasts, and also we need to distinguish what type of growth is present in this case. So either lympho or myelo. Chronic leukemia has the same classification. So chronic myeloid or myelogenous leukemia and chronic lymphocytic leukemia. I underline one point. Look here, please. Acute lymphoblastic, chronic lymphocytic. So if you answer like chronic lymphoblastic, your answer is wrong because this diagnosis is impossible. Absolutely. It could be either lymphocytic leukemia, and in this case, this is chronic process. Or it could be lymphoblastic leukemia, and in this case, it is only acute one, without any exception. Also, in chronic leukemia, we could add so-called multiple myeloma. Multiple myeloma, this is a generalized version of the plasmacytoma. Plasmacytoma, this is a tumor from plasma cells. So if this tumor is focal, this is plasmacytoma. If this tumor is generalized, so this is so-called multiple myeloma. But the origin is the same, plasma cell. So, to sum up, we have blasts, precursor cells. And these precursor cells are source of acute leukemia, lymphoblasts, and mature cell. So these cells are source for chronic leukemia, lymphocytes. So blasts are acute, cytes are chronic. So, features of leukemia. I please you really memorize these features, because in your MCQ test from topic hemoblastosis, the main basic question is about leukemia and clinical behavior of this tumor, and obviously morphological appearance. So, leukemia. Leukemia is characterized by systemic damage of all blood-forming organs, bone marrow, lymph nodes, solitary follicles, and even Peyer's patches. So, all blood-forming organs. That's why when we need to prove that this is really leukemia and this is not a lymphoma, we take a biopsy from bone marrow and see the changes here, and also we can just check the blood and also see the changes there. So, next one feature. The diaphysis of tubular bones has a metaplasia of the yellow bone marrow into the red bone marrow. So here you see the picture. So bone marrow, classically red bone marrow, we have only in the center part of the bone, and here usually yellow bone marrow, but right now you see metaplasia, yellow into the red. So this is one more example of the metaplasia. What is the reason of this metaplasia? So why this yellow bone marrow needed to become red? So, and the reason is, as you see here, a bit lower, mostly in the bottom of the slide, suppression of other hematopoietic germs, and also because of the Lycamic infiltrates. So, one by one. First of all, suppression of other hematopoietic germs. So, tumor cells spread, they proliferate, they multiply, and they spread everywhere. This is the main feature that you need to grasp in the topic of leukemia. So, Lycamic infiltrates, they like a COVID, in our modern society, so it spreads everywhere. So, Lycamic infiltrates spreads from this part of the bone marrow into this one, and that's why instead of fat here we have cells. Moreover, we have suppression of other hematopoietic germs. And again, the main reason of this is also spreading of tumor cells. So instead of different hematopoietic germs, I mean erythrocytes, thrombocytes, for example, we have only tumor cells. So there is no possibility for erythrocytes and, for example, thrombocytes to mature. There is no possibility at all, because all possible space is filled by Lycamic infiltrates. So that's why we have this metaplasia. So the main reason of all problems, especially in your MCQ, of all problems due to leukemia is Lycamic infiltrate, or actually Lycamic infiltrates, because there are a lot of. So we have Lycamic infiltrates in the wall of the vessel as well. And also we have Lycamic clots. So tumor cells attach to each other and flow in the blood, and obviously can block some small vessels, and that's why we have acute ischemia in the tissue that was supplied by this vessel, by this blocked vessel. And after the ischemia also we probably could see infarction. Next one, express degenerative changes in the internal organs. Why? I'm sure you know the answer. Because of the Lycamic infiltrates. So presence of Lycamic infiltrates obviously influences into the organ, and as you know, according to the classical scheme, so we have pathological agent, then we have adaptative resources, and when these adaptative resources are exceeded, accumulation or degeneration or dystrophy starts. So that's why we have degenerative changes in the internal organs. And finally, we have hemorrhagic, here we see with pink color, hemorrhagic syndrome. One of the most common description in your MCQ test, description of or complication of leukemia. So what does it mean? Hemorrhagic syndrome means a lot of hemorrhage. What are the causes of this problem? There are actually two main. First of all, we have suppression of other hematopoietic germs, so we do not have enough thrombocytes. Moreover, as you see, we have Lycamic infiltrates of the wall of the vessel. What does it mean? It means that we have damage of the wall. Even more, we have small ruptures of the wall. So that's why blood can just flow out from the bloodstream. That's why we have hemorrhagic syndrome. Moreover, if we have Lycamic infiltration in the liver, so liver is damaged also. In this case, we even do not have enough coagulative factors. So, what main are Lycamic infiltrates of the wall vessel that leads to the damage of the wall, and obviously suppression of other hematopoietic germs. Acute leukemia. So, precursor cells proliferation in the blood marrow more than 20%. I have already told you about this one, so one of the main diagnostic key is presence of tumor cells in the blood marrow. Oh, sorry, in the bone marrow. Next one. Lycamic infiltration consists of blast cells. Guys, blast cells. Next important feature, Lycamic hiatus. It's a common question during the seminar, and also this is a common question in your MCQ test as well. What is it? Lycamic hiatus means that we do not have middle matured cells in the blood. What I am talking about? So we have matured cells, for example, neutrophils, mature neutrophils, mature eosinophils, and they really make their function, so they work. And also we need to see some premature and some so-called young. So we do not see this premature part. We see only some young cells. So they can't make the main function of this cell. Why does it happen? You remember about depression of the germs apart from tumor precursor. So we do not have enough erythrocytes, we do not have enough thrombocytes. But with time, some already matured cells die. Yes, because of the normal apoptosis. So great example for you, erythrocyte lives 120 days. So after this time it dies due to apoptosis. That's it. So, and what do we have? We have some amount of matured cell, and our patient's bone marrow tries to produce, instead of dead cells, it tries to produce new cells, but there is no space to mature, no space for maturing for these cells. That's why bone marrow produces just young cells, so without maturing, because all space is filled by tumor cells. So that's why cells can't mature. And that's why in the blood we have still survived matured cells like thrombocytes, erythrocytes, neutrophils, so still survived, have already matured, that we have already matured. And some young cells, but there is no prematured cells. So there is no cells from this group, because these erythrocytes, erythrocytes, for example, lymphocytes, or it depends on what leukemia we are talking about, they can't mature in the bone marrow because there is just no space. Okay, move on. Lymphoblastic leukemia. This is a classical for children. Usually the age is less than 15 years. Oppositely, myeloblastic leukemia also could be in the children, but also it affects adult around the 60 years old. So that's why please pay attention when you read your MCQ condition. So what's the age? Because classically we study and we teach you that if you see young age, so this is acute leukemia. If you see more adult, this is chronic leukemia, and actually this is true. Only please be careful about the myeloblastic leukemia, because this leukemia could occur also in the adult person. So, malignant course. So, acute leukemia is malignant tumor. Obviously, it has malignant course. So, abrupt, stormy onset. That's why we can name it like acute leukemia. So, severe anemia, hemorrhagic syndrome, and that's why we have infectious complication. Poorly response on therapy. This is a feature for myeloblastic leukemia, and that's why it's really important. It's too important to differentiate. Is it lymphoblastic acute leukemia or this is acute myeloblastic leukemia? Because T lymphoblastic leukemia actually has a good response on therapy. That's why it's really important to differentiate them. So, acute leukemia. So here you see this plus tissue, pinkish color on the gingivas. So this is actually leukemic infiltrates. Moreover, these leukemic infiltrates can undergo with necrosis, and so we have infectious, and also we could have sepsis as a result of this infectious. So morphologically you see a lot of mitosis, so here 1, 2 for example, mostly small, not big cells. So here this is myeloid leukemia. Here you see some more like, I can't say that transparent nuclei, but these nuclei have a delicate nuclear chromatin. Compare with lymphoid. So here we have condensed chromatin, but cells are also round and small. Here you can see a lot of hemorrhages. So main feature or main presentation of classical feature as hemorrhagic syndrome due to the acute leukemia. And actually children can die due to the hemorrhage in the brain. It's really common. Due to the sepsis, it's also really common, especially when we're talking about necrosis of tumors infiltrates. And compare right now with chronic leukemia. Chronic leukemia, so here we have matured cells, you see. Leukemic infiltration consists of matured cells or sites. So, chronic lymphocytic or lymphocytic leukemia. So, we can't say chronic lymphoblastic. This is a mistake. So, please do not mislead. If we are talking about chronic, we are talking always about sites. So, course is more long and less malignant. What does it mean, less malignant? Chronic leukemia is also malignant tumor as an acute leukemia. But without treatment, this patient or patient with chronic leukemia can live around, for example, several 1 or 2 years without treatment. And when we're talking about acute leukemia without treatment, this patient can't live more than several months. So more abrupt course. This is about acute leukemia. More like prolonged course, this is for chronic leukemia. But both these tumors are malignant. So, chronic leukemia has two stages. First stage is monoclonal, so-called non-acute, when we have only sites. And second stage is polyclonal, when we have so-called blast crisis. So, chronic leukemia can lead to the acute leukemia. So, chronic leukemia can become acute leukemia in the second stage after the, as you see here, blast crisis. What does it mean, blast crisis? I hope it's clear, but I give a short definition. So, blast crisis, this is appearing in the chronic leukemia, appearing of the blasts. So, when we have blasts, this is, according to the terminology, this is acute leukemia. So, blast crisis of the chronic leukemia, this is like a final stage when chronic leukemia becomes acute one. So, chronic myelogenous leukemia and so-called Philadelphic chromosome. We see it at the beginning of we saw it at the beginning of the lecture, and right now we discuss some features of this leukemia that you can really apply in your MCQ test. So, all blood-forming organs are increased significantly. So, for example, in your clinical clinical cases during the practical class, you will have a case about spleen that was enlarged up to the 8 kilograms. So 8 kilograms, this is around 16 or more pounds. So a lot of. So this feature is feature for chronic myelogenous leukemia. Lymphogenous leukemia can't live to such increased in size. Can't. So significant increased in size, this is feature for chronic myelogenous leukemia. So, move on. Next difference. Myelogenous express splenomegaly and hepatomegaly and mild lymphoadenopathy. Lymphoid, on the other case, express systemic lymphoadenopathy, so more significant for lymphoid leukemia is increasing of lymph nodes, and mild splenomegaly and hepatomegaly. Bone marrow, you can also use these features. So myelogenous dirty green yellow color has a bone marrow, and lymphoid, due to the lymphoid leukemia, bone marrow has more reddish color. Move on. Different localization of leukemic lymph infiltrations in the liver. Myeloid during so along sinusoids, and lymphoid around portal triads. Right now we will see this on the example. And last one, difference. So average life expectancy. Unfortunately, myelogenous leukemia has no more than 5-7 years, and lymphoid has more good prognosis, so around the 10 and probably more years. So, and right now see all these features on the examples. So here you see significant increased lymph nodes. You see lymph nodes. So probably this is chronic lymphoid leukemia. Here you see increased spleen and liver, and this could be myeloid leukemia, but obviously, yes, so without histological and immunohistochemical test, we can't say what the disease is. So we only can suggest. So next one, so the same features, spleen, liver, and microscopical features that I actually told you. So we have a delicate nuclear chromatin. You see, so the color of the nucleus, they are mostly transparent with some like blue, small, even tiny dots. And also we have, you see, some nucleoli inside, bluish nucleoli inside. So these are features for myeloid growth, for myeloid leukemia. So again, Philadelphia chromosome, when we're talking about translocation, 9th chromosome and the 22nd chromosome. So this is a feature for chronic myeloid leukemia. So this you should memorize and even make it a tattoo in your brain. So we have, if you see the condition Philadelphia chromosome, so the right answer should be about chronic myeloid leukemia without any exception. So again, the same slide to repeat. So the test has a name like fish, and this is not a fish that we usually cook. So this is an in situ hybridization. So microscopically, that features that I have already named for you. So we have mostly round nuclei, oval or round nuclei with the delicate nuclear chromatin, some nucleoli, one, here probably, here you see 1, 2, probably there are 2 nucleoli. So when we're talking about lymphoid leukemia, here we have oppositely condensed, you see, condensed chromatin. So the cell, the nuclei of the cells, they are really blue or violet, dark blue. So compare with myeloid. And nucleoli are really inconspicuous. So probably we could see here, so this dot probably is nucleoli, but compare with this slide, yes, here it's really easy to find this nucleoli. Here, oppositely, this is really difficult. So, and also, as you see, tumor cells from lymphoid growth. So here really scant cytoplasm. So here compare, we have a bit more amount of the cytoplasm. Compare with here, you see really scant, just rim of cytoplasm. So here we could see lymphoid tumors, Lycamic infiltrates, and if you look at this picture without the name of the slide, you say that this is metastasizing process. So these are metastases. But you know that this is leukemia. That's why we can't use term metastasizing. We say that this leukemia has a dissemination. So has a dissemination. Again, so all of this tissue is infiltration. So this is tumors infiltration, and actually organ was adrenal gland. Actually, absolutely does not look like normal gland. Probably this part can help you to understand that this is true. And differences in liver. During the practical class, you will have 2 slides when you need to differentiate myeloid leukemia and the lymphoid leukemia. So, myeloid leukemia has an infiltrates between, you see, between hepatocytes. Compare with lymphoid leukemia, when we have tumors infiltrates that surrounds the portal tracts. So surround the big vessel in the center of the lobe. So portal tract. Here you see between hepatocytes, and here oppositely only they surround only the portal tract. And the last part is the multiple myeloma. So what do we have here? Here we have cells that are actually in the past, that were in the past plasma sites, or they have a precursor as plasma site. And that's why they look like a plasma cell. So they have nuclei. They have nuclei with also so-called condensed chromatin, and also they have a lot of, as you see, basophilic cytoplasm. Condensed granular chromatin. You see a lot of granules inside. So these granules are not nucleoli. So this is just granular chromatin inside. And a lot of basophilic, mostly, cytoplasm. And here we start with example of the first example of immunohistochemical test. So when we assess presence of some protein molecules on the surface of the tumor cells. So here we have lambda and here we have kappa. So these 2 markers are useful when we are talking about plasmacytoma. So classically plasmacytoma expresses only one out of them. So normal plasmacytes express both lambda and kappa, but tumor cells usually express only one out of them. So in our case we see expresses of kappa, express of kappa. So next feature of generalized form of myeloma, so we can name this like stamped caverns. What does it mean? So classically myeloma affects flat tissue. That's why we can find it in the scalp and in the vertebra. So these 2 locations are the most common. And also you could find in your MCQ test this term stamped caverns, or actually stamped caverns. So a lot of caverns that are near to each other. So like here, 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 and probably here. Not so near actually, but these two could be here and here. One big and there are two small. Also here you see the accumulation of tumor cells. This is not, as you see, flat bone, obviously, but classically multiple myeloma affects flat bones. I like this slide very much. So actually 1 hour, our lecture takes 1 hour. So if you are really tired, if your brain really tired, I absolutely understand, because it's really difficult topic, a lot of word, really. So press a pause, take a breath, bring a cup of coffee, and we continue with the second part, because second part of the lecture is about lymphomas, and the amount of the information will be mostly the same as it was in the first part. So if you really need to stop and take a breath, do it. Do it right now. So move on. Lymphoma. I repeat again. Lymphoma, oppositely to leukemia, is a focal process. Focal process means that lymphoma affects classically lymph node 1 or group of lymph nodes, or it could be in the one organ, like thymus, like spleen, for example, but focal. So if we take a biopsy from bone marrow, there is no changes. If we check a blood, there is no tumor cells at all. That's why this is lymphoma. So answer the question, how can we distinguish lymphoma from leukemia? You need to tell about spreading of the process and about the changes in the blood, yes, and in the bone marrow. So lymphomas could be divided into two main groups. So two main groups: Hodgkin lymphoma and non-Hodgkin lymphoma. Actually, Hodgkin lymphoma is a one disease, only one Hodgkin lymphoma. That's it. There are 5 main variants probably, but this is still one disease. And all other types of lymphoma are included in the group of non-Hodgkin lymphoma. That's it. So Hodgkin lymphoma could be classical. There are 4 main variants, and we right now see each of them. And the non-classical variant, so-called nodular lymphocyte predominance. So, and non-Hodgkin lymphoma is divided into 2 groups as well. So this is mature T cell and mature B cell neoplasm. Again, non-Hodgkin lymphoma is divided into 2 groups, from T cells and from B cells. Very easy. What is your main task you need to memorize features of Hodgkin's lymphoma. What is this? So what are main histological features and what are main histological variants? And also you need to remember that Hodgkin lymphoma has one of the best prognosis for life among all with lymphomas. It's important. About the non-Hodgkin lymphoma, what do you need to remember? You need to remember that we have two main groups, T cell and B cell. And you need to know no less than 2-3 examples from each group. That's it. So right now we discuss all these obligatory, I can say like this, obligatory types of or variants of lymphomas. So if you continue to listen to this lecture, I think that all important information will be included, I hope. So, this is a list of lymphomas. Actually, this list is not completed. So, according to the classification of the WHO, World Health Organization, there are around 200 types of lymphomas. So, that's why this is just a list to show you that the amount of lymphomas is really huge, massive. So you need to remember just several examples. I think this is not a difficult task. I hope. I believe in you, dear students. So to start with, I repeat with you the structure of the normal lymph node. So each lymph node has a cortex with the lymphoid follicle, primary, and secondary lymphoid follicle with so-called germinal center. So this is normal structure of the lymph node. Also, there is some medulla. And also there is a paracortex where we have a lot of T lymphocyte. So, as you see on this picture, there is a normal lymph node that you can really see under the microscope. So, previous slide was a scheme. And right now you see the real situation. So what do you see? You see lymphoid follicle with more light part germinal center. Some cells, lymphoid cells, between these lymphoid follicles. And these absolutely light cells with light cytoplasm, these are so-called sinuses. So, lymphoid follicle, this is germinal center, and this is the part of B cell as well for lymphoid follicle. And here also you could see primary follicle, you see? So there is no germinal center inside. So, and according to the origin of the lymphoma, we name it. What do we have? If a lymphoma arises from this part, I say like more condensed, yes, more dark part of the lymphoid follicle. So this part has a name as mantle zone. So that's why this is mantle cell lymphoma. If we are talking about more like this line, so cells that are close to the mantle zone. So this is Where is it? On this slide, I do not see it. Okay. Just omit. So, germinal center. Germinal center, from the central sites we have B cell, large cell lymphoma. Whole lymphoid follicle gives us follicular lymphoma. Next one, some cells from germinal center gives us Hodgkin's lymphoma. And also plasma cells, also from germinal center, because they appear there. So this is plasmacytoma or myeloma. And also chronic lymphoid leukemia. It's very interesting feature actually. That some lymphomas has like a brother in the group of leukemias. What does it mean, brother? So if this tumor is focal, we name it like lymphoma. If this tumor is generalized, we name it like leukemia. So one example we have already discussed with you. So multiple myeloma. Multiple myeloma, this is generalized version of focal plasmacytoma. And next example is chronic lymphoid leukemia. So this tumor has a focal version like lymphoma from small lymphocytes. Lymphoma from small lymphocytes. So one more interesting feature of hemoblastosis: they can change their appearance. This feature is really interesting. Why? Because only hemoblastosis can this. So this ability has only lymphomas, lymphoma or leukemia. I mean hemoblastosis. What does it mean? So patient has an enlarged lymph node in the neck. So the physician takes a biopsy, and the pathologist makes a diagnosis as let it be follicular lymphoma, like you see here. So move on. Patient is treated by specific protocol for this tumor, and there is a remission. Through several months or several years, for example, we have again increased lymph nodes in the neck. And what? We need to take a biopsy again. And we do this. And right now we have another tumor. Right now we have diffuse large B cell lymphoma. So this is transformation from one tumor into the another. So this is possible only for hemoblastosis. Moreover, if, for example, we are talking about carcinomas, so patient was taken a biopsy, and there is, for example, biopsy from the lung, and there is a squamous cell carcinoma. Patient have been smoking for 20 years. So the focus of the carcinoma was eliminated surgically. And through several months, there is a focus again in the lung. So biopsy was taken again. And there is, for example, adenocarcinoma, for example. So this is impossible. So it means, so if you have the situation like this, it means that firstly, the diagnosis was made incorrect. Absolutely. So the diagnosis was wrong. Or right now, secondly, after the second biopsy, the diagnosis is wrong. The diagnosis is wrong because this is impossible. Only only lymphomas have this situation. Only lymphomas can transform from one type into the another. So we have transformation in the hemoblastosis, and this is not rare situation. Follicular lymphoma can transform into the diffuse large B-cell lymphoma. Mantle lymphoma, the same. And also lymphoma from small lymphocytes also can transform into the diffuse large B-cell lymphoma, and this process has a name, Richter syndrome. Okay, so this is the main list of diseases that you need to remember when we are talking about group of B-cell lymphomas. So, move on. Practical skill. This is lymph node. What do you exactly see? So here this is lymphoid follicles without germinal center, with germinal center, but this part of the lymph node, you see so-called erased picture of the lymph node. So here you do not see lymphoid follicles. It's really easy to see. So here, exactly here, we have a problem, and we need to use so we need to see it more close to find out what's going on. So Thomas Hodgkin, he actually first time named the disease as the Hodgkin lymphoma. Classically, Hodgkin lymphoma affects lymph nodes of the neck. Also could be affected spleen, liver, so other organs. When we're talking about affected spleen, we have a specific name, so-called porphyry spleen. Porphyry, because of the color of the spleen. So here you see, so this is normal tissue of the spleen, and this is exact problem. So porphyry spleen, you can use this term in your MCQ test like a key, like a tip. So porphyry spleen, this is a feature for Hodgkin lymphoma. Compare with Lardeschius spleen, remember? This feature is for amyloidosis of the spleen. Lardeschius spleen or Sago spleen is also feature for amyloidosis. Sago spleen is the first stage and Lardeschius spleen is the second stage of the amyloidosis of the spleen. So stages of Hodgkin lymphoma. When we are talking about first stage, so we have only one group of lymph nodes affected. So the prognosis for life and for surviving is around 95%. So this is really good. Actually, one of the best possible diagnoses out of all types of lymphomas. So second stage, when we have two focuses of lymph nodes affected, and but both of these two focuses are upper or lower than diaphragm, but they are both on the same side. For example, like this. So these both focuses are upper than diaphragm. So the third stage, when we have two focuses or affected organ, like spleen, for example, but these focuses locate these focuses are separated by diaphragm. And for fourth stage, clinical stage, when we're talking about multiple affected focuses at the both sides of the diaphragm. Obviously, prognosis here and prognosis here are absolutely different. So here is around, as I told you, 95%, and here is around, actually no more than 15, even less. So microscopical appearance you need to memorize, and here you need to make a tattoo for sure in your brain, because about the MCQ about the Hodgkin disease, about the Hodgkin lymphoma, is one of the most common in our subject. So not just in the topic of hemoblastosis. In our subject, this is one of the most common questions. So Hodgkin disease has a specific cell. This cell has a really long name. It depends on literature what you read. So if you read just Western world literature, so there is just read Sternberg cell. If we read the literature of the Eastern world, so here we have also name Berezovsky. So in Eastern world literature, you can find name like Berezovsky read Sternberg. So it depends on, you see, time when these scientists at first time saw this cell. So what is this? So you see a big cell. You see a lot of cytoplasm. Inside this cell, there are classically two nuclei. And inside each nuclei, one big nucleoli. In literature, you can find the term like owl eyes. So eyes of the owl, as you see on the picture. So probably, yes, if you turn on your imagination, it really looks like owl. So again, big amount of the cytoplasm, two big nuclei with one big nucleoli. So this is classical description of the Berezovsky-Rich-Sternberg cell. And right now a lot of examples of it. So cytoplasm and this big nuclei with big nucleoli. Again, cytoplasm with big nucleoli, big nuclei, as usual. This cell, as you see, we can name like Hodgkin cell. So there is just one nuclei with nucleoli. Actually, there is a huge list of specific cells in the Hodgkin lymphoma, but diagnostic cells are only Rich-Sternberg. So this cell is so-called popcorn cell. Why popcorn? Because you see a lot of nuclei with nucleoli as well, but a lot of nuclei. So again, if you turn on your imagination, probably it looks like popcorn. Anyway, so Rich-Sternberg cell has just two nuclei with two nucleoli. Here, as you see, there are a lot of. This cell has a name like LP cell, also specific cell for Hodgkin lymphoma, but I underline again and again, diagnostic cell. So if you find this cell, what does it mean, diagnostic cell? Diagnostic cell means that if you see this cell, this is for sure Hodgkin lymphoma. So diagnostic cell only is Rich-Sternberg. So immunohistochemical test. Brownish color, as you see, a brownish color surrounds specific cells. So these specific cells are tumor cells for Hodgkin lymphoma, and marker is CD30. CD30 means cluster of differentiation number 30. So CD30 gives us a possibility to see exactly Rich-Sternberg cells. CD15 also gives us a possibility to see these cells. Again, so classical membranous coloring and EPS coloring, EPR, sorry, and the plasmic reticulum. So, morphological variants. As I told you, there are main 5. So, non-classical nodular lymphocyte predominance and classical. Lymphocyte rich, lymphocyte depleted, mixed cellular, and nodular sclerosis. There are two, the most common, mixed and nodular sclerosis. And fortunately, these two have a good prognosis. So, non-classical variants has this popcorn cells, a lot of popcorn cells. Actually, Rich-Sternberg cells was previously B lymphocyte, but they lose their differentiation, and the marker for B lymphocyte classically does not express on this rich tempered cell. But non-classical variants, that's why this variant is not a classical. So we have expression of the CD20, as you see here, on the surface of the tumor cells. So in the non-classical variant, tumor does not completely lose the B cell differentiation. So in the classical lymphoma Hodgkin, tumor cells completely lose B cell differentiation. Here, just partly. Also, marker AMR is positive, as you see here. And CD3, this is marker for T lymphocytes. So, as you see, T lymphocytes surrounds the tumor cells. You see here, they just like make a circle around these tumor cells. So, again, this is a diagnostic feature for Hodgkin lymphoma, when T lymphocytes try to cope with these tumor cells and make this, in some literature you can find like garden surrounds tumor cells. So, classical variant lymphocyte rich. What does it mean? It means that we have just a few tumor cells and a lot of lymphocytes, especially T lymphocytes. Nodular sclerosis, the most common variant. So we have formation of connective tissue, and this connective tissue forms a circle. And inside this circle, we have some lymphocytes and a lot of tumor cells. Tumor cells, so-called LP cells or and lacunar cells. Mixed also the most common, as nodular sclerosis, also has a good prognosis. So here we have both a lot of tumor cells and a lot of infiltration, non-tumor, so infiltration with T lymphocytes, macrophages, monocytes, so histiocytes as well. And lymphocyte depleted, so there is mostly no infiltration from other cells. There are mostly only tumor cells. Classically, this variant of Hodgkin lymphoma has the worst prognosis. Next one, diffuse large B-cell lymphoma. So here we have, according to the name, you see, large. So we have big tumor cells with several nuclei. This tumor also has 4 histological variants: centroblastic, anaplastic, immunoblastic, and T-rich variant, but the most common is the centroblastic variant. So when we have tumor cells with classical this appearance, so tumor cells are big with I can say like delicate nuclear chromatin and several big nucleoli. Also, all lymphomas have increased mitotic activity. obviously, when we're talking about so-called indolent lymphomas, so without classical malignant course, yes, here mitotic activity will be significantly low compared with lymphomas and especially acute leukemias with so-called absolutely malignant course. But diffuse large cell lymphoma is one of that lymphomas that have increased mitotic rate. So here you see one mitotic figure, second, third, fourth. So 4 mitotic figures just in one field of view. It's really big amount. Could be bigger, to be honest, but this is also big. So again, classically we have increased lymph nodes in the neck, on the neck. Also could be affected organs. Also could be affected CNS. It could be so-called primary diffuse large B-cell lymphoma of the CNS. So when we do not have any other affected location apart from CNS, so this is primary lymphoma of the CNS. So, and more examples of presence of the tumor. And as you see, so lymph node, so this exact tumor, again, lymph nodes, they are completely attached to each other. So this is, it was a group of lymph nodes, but right now this is a big one lymph node. So, and immunohistochemically, so we have CD20 plus, you see, so because this is B cells, that's why CD20 plus, and BCL2, as you see, minus, could be plus, but on this example you see minus also feature for lymphomas. And these two markers gives us a possibility to say that this is like subvariant from germinal center. So we have two subvariants, non-germinal cell and from germinal cell. So BCL6 plus and CD10 plus gives us the possibility to say that this is variant from germinal cells, subvariant of centroblastic variant of diffuse large B-cell lymphoma. Finally, follicular lymphoma. We actually have already told about it. So, and right now we see exact example. So we have a follicles, lymphoid follicles with different shape, with different size. Here you see completely different size. This is in 2, in 3 even times less than this one. So different shape. This is more like oval. This is more like round. Without germinal centers. Classically, lymphoid or classically follicular lymphoma also affects lymph nodes, but also follicular lymphoma has an extranodal variant, and primary extranodal follicular lymphoma classically affects skin. Again, we have already told about it. So translocation from 14 and 18 chromosome. So this is a key feature for follicular lymphoma. Next one lymphoma is Burkitt lymphoma. key feature that you need to use in this disease in your MCQ, for this disease in your MCQ test, is so-called starry sky. So you see these granules in the mostly empty space. So a lot of granules, small granules in the empty spaces. So if you turn on your imagination, probably you see the stars on the sky. That's why starry sky. But what is this exactly? As we said, so all lymphomas have increased mitotic activity. So lymphomas proliferate really quickly. So that's why we have not only increased or even high mitotic index, but also we have a lot of apoptosis in this tumor. And these apoptotic rests or apoptotic bodies, if you remember from the topic cell death, so classically these apoptotic bodies are phagocyted by macrophages. So, and here this empty space, actually this is not an empty space, this is macrophage that phagocytes these apoptotic bodies. So that's why classical appearance for Burkitt lymphoma is presence of starry sky, but do not forget that these stars are just apoptotic bodies. And also Burkitt lymphoma has very even one of the most highest mitotic activity. And that's why Burkitt lymphoma has an abrupt course. So in this, according to this criterion, Burkitt lymphoma is familiar to acute leukemia. So really onset and really quick development of the disease. So as you see here, we have again lymph nodes of the neck are affected, and also Burkitt lymphoma commonly affects intestine. So microscopically, again, this starry sky, CD20 plus, because this is B-cell lymphoma, please do not forget. And as you see, marker Ki67. Ki67, this is a marker for exactly proliferation. So this marker shows us which cell is ready to divide. So which cell is ready to divide into two. So which cell is ready to proliferate. And as you see, according to the coloring, so mostly each cell is ready to proliferate. So 99 or 98% of tumor cells in one moment are ready to divide. So you can imagine the speed of increasing the mass of the tumor. If in one moment each cell, mostly each cell, ready to divide into two cells. So that's why we have abrupt course and onset beginning. And second group is T-cell lymphomas. So the most common is T-cell lymphoma, non-other specified, or so-called NOS. So this type of lymphomas takes around 30% of whole T-cell lymphomas. Men are affected in 2 times commonly compared with women, and usually the size of cell is smaller compared with B-cell lymphomas. And the most important feature is positive reaction with CD3. CD3 marker of T-cell differentiation. So instead of CD20 here, CD3 is positive. So that's why this is T-cell lymphoma. Questions that you find in your MCQ. Absolutely sure. I'm absolutely sure. So, mycosis fungoides. This is primary T-cell lymphoma. Actually, this lymphoma accounts around the 50% of all skin lymphomas. So this is not so rare situation. This lymphoma affects mostly only skin and has long duration. So this is an example of so-called indolent lymphomas. So they have a long duration. So there is a long time without classical malignant clinical course. So what do we have microscopically? Microscopically, we have specific, as you see here, specific clusters, even I can say like this, clusters of tumor cells inside, so in the epidermis. So here, very good, very easy to see. So these clusters have a specific name, and name is microabscess of Poirier. And CD4 is marker of T cell differentiation as well, and this marker shows us positive reaction of these clusters inside the epidermis. So, to sum up, hemoblastosis is really difficult and absolutely, utterly fascinating topic. There are a lot of diseases with absolutely unique features. For example, one tumor can become another one, and this is not a mistake, this is a possible situation. Moreover, we can't use term metastasis, we need to use only dissemination. All tumors are malignant, and provided this fact that all tumors are malignant, they have a different clinical course. And clinical course absolutely depends on name of the tumor. Usually, acute leukemia affects young or children, young person or children. But we have acute myeloid leukemia that affects adult person around the 60. Some tumors like Hodgkin lymphoma has 2 possible ages, like around the 15, 20 years, and then 55 and 60 years. So, hemoblastosis is a group of tumors with a lot of controversy, a lot of diseases with different with different prognosis and with different clinical behavior. And here clinical behavior depends on both, as usually for malignant tumors, on stage, when you catch your patient, but this end does not have less importance. And accuracy of the diagnosis. About if this is acute lymphoid leukemia, so treatment works. If this acute myeloid leukemia, treatment unfortunately mostly does not work. But both are leukemias, both are acute one, but we need to differentiate the type of the growth. Is it acute is it lymphoid or this is myeloid? It's really important. So I wish you really good luck to get into this point, get into this topic. It's really interesting, but it's really difficult. If you need to have level just to pass it, no problem, it's okay. So you need to know the main definition, main classifications, and several examples in each type of the classification. In each type, I can say even in the classification. So, I wish you good luck. I hope you do your best and you show a high level of knowledge, because you can do this. Have a nice day. Stay healthy in our really difficult time, and see you next time.